Hola, everyone, and welcome to week 3, where we will be discussing recognition and pattern identification. The more slides and manual differentials you review, the easier hematology becomes. This week's lesson is titled White Blood Cells and Differential Review, and I'm your host, Tanisha Wallace. And let's get started. Week 3 objectives will be differentiate granulocytes versus agranulocytes, ID normal maturation stages, recognize reactive versus malignant changes, correlate morphology with disease, and strengthening manual differential interpretations. So I put here, we're going to review the big picture. White blood cells protect the body from infection, inflammation, foreign invaders. Their function have a host defense, inflammation, immune regulation, and phagocytosis. So I have here the different type of white blood cells. You got leukocytes, or white blood cells are part of the immune system. They account for less than 1% of, give or take, of the blood volume and occur in the lymphatic tissue. We have the neutrophils, which are a multi-lobe nucleus that help kill bacteria and fungi. We got basophils, or bi or tri-lobe nucleus, and they are there for inflammatory responses. We've got eosinophils, which are bi-lobe nucleus, and they kill parasites and allergic responses. We have monocytes, which are agranular, so there should not be any granules in these. Monocytes are kidney-shaped nucleus, and they remove dead cells. And we also have lymphocytes, which are a centric nucleus, and they kill viruses and make antibodies. So a memory trick, granulars equal granulocytes. There are two groups, granulocytes and agranules. So we got neutrophils, eosinophils, and basophils. Remember, those are our lobed ones. They look grainy. They're gonna interact with different. I'm sorry, got a little sidetracked real quick. They are part of our granulocytes. White blood cell abnormalities. This is like an MLS pearl. You may involve quantity, morphology, function, and maturation. Leukocyte classifications. You got granulocytes, agranulocytes. We just spoke about that. We got neutrophils, lymphocytes, eosinophils, monocytes, and basophils. The stages or linearity, when you are looking at the lineage, myeloblasts, polymyelocytes, myelocytes, metamyelocytes, band, and segmented neutrophils. The 3 granulocytes, they're going to have, you're going to have your cell. It's going to be your neutrophil. Again, they're going to help fight bacterial. They're for bacterial defense. That's their main function. Eosinophils, again, help fight parasites and allergies. Basophils have histamine releases. So they're going to help when you have some type of flare-up. Easy memory. Neutrophils neutralize, eosinophils handle allergies, and basophils burst histamines. Neutrophils are the most common white blood cell responder to bacterial infection. What you should notice about a neutrophil is a segmented nucleus, pale granules, and left shift during infection. This is a high yield. Neutrophilia plus bands plus toxic changes equal think bacteria infection. So neutrophilia plus bands plus toxic granulocytes or toxic changes, think bacterial infection. Eosinophils involve parasitic infections, asthma, and allergies. Key findings, they're orange, red granules, and bilobe nucleus. Eosinophils help fight worms and wheezing. Okay, that's a memory hack for you. Basophils release. They are histamines and heparin. They have dark granulars, and granulars may obstruct nucleus. So just think of them, the real bumpy uncle. High yield association basophilia strongly is associated with CML. Again, basophilia is strongly associated with CML. So granulocyte functions. Granulocytes help with phagocytosis, inflammation, hypersensitivity reactions, and immune signaling. Granulocyte disorders. You should be able to connect granulocytes with infection, inflammation, or inflammatory disorders, leukemias, myeloproliferative diseases or disorders. And one important thing you should try to remember for MLS connections, granulocyte abnormalities may involve count changes, toxic changes, maturation defects, malignant proliferations, and the maturation for granulocytes. As a granular matures, the nucleus is condensed, the chromatin clumps, and granules become specialized. Immature cells have a fine chromatin and a nuclei, and mature cells will be segmented nuclei, clumped chromatin. Okay, so just a memory hack. Mature cells look darker and more organized. Okay, again, mature cells look darker and more organized. Let's try to connect left shift. So granular sites are commonly involved in left shifts. This occurs when the marrow releases immature neutrophils during infections or stress. So you're going to have toxic changes. Granulocytes, especially neutrophils, may show toxic granulization, doughy bodies, and vacuoles. That should be a telltale that your body is trying to fight off something. These suggestions will interpret severe infections or inflammation. Connect the dot type of things. So the takeaway from this, to help you remember, or for you to think about it when you're reviewing this, is this a mature cell or an immature cell? Do I see any toxic granulars, or is this normal? Is this reactive or malignant? Those are some things you should be looking out for when you're trying to answer some of these questions on the MLS. And which granular site is increasing? Do we have an uptick in neutrophils, uptick in eosinophils, basophils, or anything like that, okay? Whew. So high yield granular site comparisons, when you're going to look at these, and I'm telling you all this now because we're going to keep reviewing as this slide goes, so bear with me. You're going to have the granulars and the cell color. Think about the cell color. What does that chromatin look like? How big is this nucleus? When you look at the neutrophil, it should be pale and like or lilac, have 2 to 5 lobes, and it helps fight bacteria. If you see any eosinophils, they're going to be orange looking or red bilobed. They're there. If you see those, they're there for parasites or allergies. Often basophils will be dark blue, often hidden. Think histamines. And one final note that you could take from this, granular sites are central, okay, which means they're central to infections, inflammation, leukemia, interpretations of differential counts, okay? The MLS exam frequently tests morphology and disease association together. So, granulocytes are the body's rapid response defense team, and each one responds to a different type of problem. That helps students connect morphology, function, and clinical significance together. Okay. Let's move on to agranulocytes. All right. So let's talk about the morphology. So agranulocytes, excuse me, We're going to talk about their size, the nucleus shape, the chromatin pattern, cytoplasm amount, and color. All right. You can be able to tell lymphocytes from monocytes, blasts from reactive lymphs. Okay. So, what does the lymphocyte function? What is its function? It has an adaptive immunity, and they have antibodies, and they respond to viral responses. Monocytes are phagocytosis, which means they're part of the cleanup crew, and macrophages, which are precursors. Those are things that also that monocytes help find and get rid of. One way you can remember that is lymphs. You remember monos clean. Lymphs remember and monos clean. Lymphs remember and monos clean. All right. Reactive versus malignant. Very important for MLS. Reactive and lymphocytes. So I'm going to talk a little bit about lymphoblasts first. If you have a high yield comparison where you have some reactive lymphoblasts, mature chromatin, fine chromatin, irregular shape, uniform, immature appearance, think of a viral infection or leukemia. Consider more with the cytoplasm if it's a high to nucleus ratio or just looking steady with the ratio of the cytoplasm. Here's a way for you to remember this, a memory trick. Reactive lymphs react and blasts invade. Reactive lymphs react and blasts invade. Okay. Lymphocyte disorders. We're going to talk about reactive lymphocytosis or CLL and AML. So it's important to associate finding disease, much cells, CLL, or childhood leukemias all together. Okay, so if you see those, just remember, you ain't supposed to be here. And that's why when you talk to people who know that they're not supposed to be doing certain things, they just look at you or look away or they avoid you. Telltale. So let's talk about CLL, which has smudge cells, and it's a childhood leukemia. All right, versus what you would spend for an adult. Reactive lymphs or viral infections, this would fall underneath our monocytes. All right, so monocytosis is there because of chronic inflammation or CMML. CMML. All right. Sorry. Here we go. And one other memory trick is monocytes rise during cleanup and chronic problems. Okay. Cell comparisons, which is very important. Okay. Monocytes versus lymphocytes, reactive lymphs versus blast versus mature lymphocytes. Got a comparison chart. We're going to get to it. So just try to remember what the nucleus and cytoplasm is supposed to look like for these cells. Lymphocytes are round, thin, and rimmy mostly. Nucleus. Monocytes fold gray, blue, largest white blood cell, and then you don't see them anymore. Okay. And then you're going to have minimal nucleus with this here when we're talking about blasts. One thing you can remember is when you have neutrophilia, it's going to be bacterial. If you have lymphocytosis, you don't think viral, and if you have monocytosis, chronic inflammation. So neutrophilia, bacteria, lymphocytosis, viral, and monocytosis, chronic inflammation. All All right, just making sure I have everything here. Okay, moving on, people. All right. Oh, I left a cute little memory hack on here. Memory: never eat bad lunches. So if you need to remember your leukocytes, neutrophil, eosinophils, basophils, and lymphocytes. All right, we're moving on here. Neutrophils. I'm gonna go over these again. I'm gonna get this in your head, even though I know you know it. It's a good refresher. Too many lobes equal DNA problems. So neutrophils are our primary um, granulocytes. Their role is for bacterial defense, acute inflammation, and they're normally between 50 to 70%. Again, neutrophilia, if you see that in someone, think bacterial infection, stress response, steroids, myeloproliferative disorders. Okay. I already talked about that. Their chromatin will be clumpy and it should look fine or granular-like. If you have hyperpigmentation, which is 5 or more lobes, this is usually associated with B12 deficiencies and folate deficiencies. Neutrophils are the most common white blood cells in the peripheral blood and are one of the almost important cells in hematology. Think of neutrophils as the body's first response. When the bacteria enters the body, neutrophils are usually the first cells sent to fight the infection. A normal percentage, again, for neutrophils is 50 to 70% of the circulating white blood cells. Because they are so common, abnormalities involving neutrophil appear frequently on MLS exams. Keep that in mind. All right. And this is a little memory trick. Neutrophils equal neutralize bacteria. What is its main function? It's to engulf bacteria, phagocytosis, destroy microorganisms, and all right. So what else does neutrophils do? They tend to engulf the bacteria, kind of like a monocyte, because they also have association with phagocytosis, and they destroy microorganisms participating in acute inflammation. So yay, neutrophils. They contain enzymes and granulars that help kill pathogens. And neutrophilia morphology. Mature neutrophilia is also called segmented neutrophils or SEG. All right. I want to talk about some characteristics. Again, 2 to 5 lobes, pale pink cytoplasm, fine lilac granules, and clump chromatin. One memory hack is segments are mature soldiers. Okay. Segmented nucleus. The segmented nucleus is important because segmentation indicates maturity. All right. If there are too many lobes, think hypersegmentation. If there are no segments, think bands. Hypersegmentation neutrophilia. Oh. All right, and we talked about the 5 lobes or more is associated with B12 deficiency and folate deficiency. Too many lobes equal DNA problems. So we don't want to see all those lobes in our neutrophils. All right. Other common causes of neutrophilia would be bacterial infection, inflammation, stress, steroids, and tissue necrosis. When you think of bacterial infection, think of neutrophilia and its counterpart, I should say, which would be helps with the lymph epidemic. not epidemic, but with the neutrophilia. Left plus a bacterial infection is going to equal neutrophilia plus left shift. Neutropenia. What causes neutropenia? Less, not enough. It decreased in numbers. Chemotherapy, viral infections, bone marrow suppressions, and severe toxic. Severe sepsis. Important to connect. Severe neutropenia increases risk for bacterial and fungal infections. And any type of toxic changes, neutrophilia may show toxic changes during severe or they never die. You see what? Okay. Boop, 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 boop. Toxic granulations, Dolly bodies, and vacuoles. Those are indications if there is some type of disorder going on. Active bone marrow responses to stress, and one memory trick you can use is active marrow response to stress, and toxic neutrophils look stressed. And then you have our left shift here. Well, you know what causes left shifts? Mm-hmm. All right, left shifts increase in immature neutrophils or bands. This occurs because the marrow is releasing cells early during infection. All right, primary granules, second granules. These granules contain enzymes that destroy bacteria and neutrophils in the manual differentials. When identifying neutrophils, look for segmented nucleus, pale cytoplasm, fine granulars, clumped chromatin, and neutrophils versus bands. All right. Try not to confuse band with segmented neutrophils, horseshoe nucleus, lobe nucleus, immature. Know the difference. No filaments, no filaments, and thin filaments are present. All right. If you see neutrophilia, left shift, toxic granulocytes. I'm trying to make sure there's nothing else I need to hit on. All right. Think about this. I found this interesting. Neutrophils are heavily involved in pneumonia, sepsis, appendicitis, and acute bacterial infections. Okay. Final thoughts on neutrophils. Neutrophils are the emergency response team for bacterial infections, and they help connect morphology, function, and clinical significance together. Next, we're going to have bands and left shift. Immature neutrophils, non-segmented, and nucleus. That is the description of a band. Excuse me. If you get left shift, it's increased in number of immatures in the body. And it's very much well seen in sepsis, individuals that come into our hospital. So we will see a lots of bands, and we do see that. Okay, and then here we go. All right. Remember, increased immature neutrophils are released into the circulation. Bands are left shifts, and very important to concepts in hematology, and a very invested test on me or on my subject. All right. Okay. Let me see if I can get this finished now. All right. Not sure where I left off at, but we're going to talk about bands and left shifts. The big idea is bone marrow is responding to stress and infection when you see in bands and left shift. Band is an immature neutrophil. All right. And it is in one stage before a fully mature neutrophil. Remember that maturation sequence is myeloblast, promyelocyte, myelocyte, metamyelocyte, band, and segmented neutrophil. Bands come before segments. And band morphology, bands are shaped like a horseshoe, has a horseshoe nucleus and curved nucleus. No true segmentation. The nucleus should not have thin filaments separating lobes. That means it is a seg. Once segmentation occurs, it becomes a segmented neutrophil. Remember trick, bands equal banana nucleus. What is left shift? So left shift increases in immature neutrophils in circulation. Bands increase first, sometimes metamyelocytes and myelocytes appear. So a memory trick for you is left shifts equal marrow working over time. Why it is called left shift is because historically, immature cells were placed on the left side of the laboratory maturation chart. So when more immature cells appear, the count shifts left. Cause of left shift, mostly common, it is because of bacterial infection, inflammation, sepsis, tissue injury, or stress response. Here's a little pearl for you. Left shift usually indicates increased marrow response to demand. The marrow is trying to send help quickly. Bands in infection. During severe infection, you're going to have an influx of mature neutrophils get used up rapidly, and marrow releases bands early to compensate. This is why bands increase during bacterial infection. Another memory trick, the marrow sends backup early. So left shift versus leukemia. This is very important, okay? Reactive infection-related orderly maturation still presents leukemia abnormal proliferation. Blast dominant, not bands, will dominate maturation, may become disrupted. So if you see bands, toxic granulocytes, or Dolly bodies, that's infection, a reactive process, not leukemia. Blasts have blast nuclei in very immature cells. Think leukemia and malignancies. Not an infection, but this is something more severe when you see blasts. Think of leukocytes at this point. So leukocyte reactions is a severe left shift with very high white blood cell count and may be called leukocyte reaction. This is not leukemia. It can mimic leukemia. It is caused by severe infection, sepsis, and inflammation. So an important is in a leukocyte reaction, you got to look at it's going to have a high LAP score or CML. Malignancy will be low, LAP score, and basophils. So LAP helps separate leukocytes from leukemia. And an absolute band count, when you're looking at an MLS exam, it may ask for absolute count. This is just based on the left shift increase for absolute immature cells like neutrophils, not just the percentage. And I'll break that down a little more later. So segmented neutrophils, you should have roughly 2 to 5 lobes. They have a clump chromatin and they are fully functional. Bands are immature but still function. But they're still functional, I'm sorry. Important MLS connection. A left shift often appears together with neutrophilia, toxic changes, or infection markers. This helps correlate morphology with chronic disease. A left shift means the marrow is pushing neutrophils out early because the body needs help fast. That connection helps them remember both the morphology and the clinical meaning. Okay? So, let's keep going here. One memento. Okay, we're going to get through this. I'm trying to do this within an hour. So here's toxic changes. This is what you would see in a severe bacterial infection. So this could be septic infection, think bacterial infection. So here's a memory trick. Toxic cells look stressed. Major toxic changes. There are 3 major toxic changes you absolutely need to recognize. Toxic granulation, which is over here in number 1. And then you have your Dolly bodies. I'm sorry, I left the 2 dots off of the O. And then you have your vacuoles. So you see these little blue cytoplasmic inclusions. Those are Dolly bodies. And you see the vacuoles all in here. That is a sign of toxic granulation in number 1. Dark coarse granules in the neutrophils. These granules are more prominent than normal and indicate an increased enzyme activity. Why does this happen? The marrow is speeding up neutrophil production during infection. The neutrophils retain more prominent granules than usual. Dark granules are angry neutrophils. So remember, they're like, oh my God, you got me out here working overtime. Here's another pearl. Toxic granulation strongly suggests bacterial infection, sepsis, or severe inflammation. Let's talk about number 2, which is Dolly bodies. Why are they here? These are small, pale blue inclusions found in the cytoplasm of the neutrophils, usually located around the edges, and they are rough endoplasmic reticulum. So this is just RNA remnants, okay? And here's how you remember why their Dolly bodies are here. They're little blue stress. Remember, our cells are stressed when we see these. So with Dolly bodies, Dolly bodies are going to commonly be seen in infections, burns, pregnancies, and inflammations. I'm going to say it again. Infection, burns, pregnancies, and inflammation. So you would not see them on a regular. And why would we see cytoplasmic vacuoles like we see here in this cell? You can see those clear holes or spaces in the cytoplasm. Those are vacuoles. And these should not be in other cells because what the? This is active phagocytosis. The neutrophil is actively eating bacteria or debris. I put this here even though this is not a neutrophil, but because I wanted you to see how vacuoles look inside of the neutrophil. So my apologies for that. But this would mean the cell and the neutrophil is under attack. But I wanted you to see what the vacuoles will look like, and you've seen that before. So that means that the neutrophil is actively eating bacteria or debris. So don't get this cell here confused with a seg because it's not a seg. Vacuoles mean the cell is feeding. Vacuoles mean that there's severe infection, sepsis, or some type of toxic state. Always remember, old blood specimens can also create artificial vacuoles as well. Toxic changes versus blast. So this is why I put this here too. Toxic changes and blasts. So toxic changes with neutrophils, they're mature. Blasts are immature cells. Neutrophils respond to infection. Blasts are a response to leukemia. Neutrophils have coarse granules and blasts have fine chromatin. Neutrophils are have segmented nucleus. Remember, 2 to 5 lobes. Blasts are large, immature, and that's what their nucleus looks like. It looks like a cyclops. And I got some more slides for you for this down the way. Toxic changes are usually reactive and reactive to a marrow response. And blasts are malignant, concerned, immature, and abnormal. Should not be getting those at all. In left shift connection, toxic changes are often seen with a left shift. Remember, toxic changes are seen with the left shift. That means increased bands, immature granulocytes, active marrow response. Remember, neutrophils are there. There are foot soldiers. There are regular police patrolling the area. So when we have a left shift plus toxic changes, it equals infection until proven otherwise. You have to prove me wrong that I don't have an infection. And then if it's not an infection, I must have some inflammation somewhere. So on the MLS test, when you see toxic granulations, Dolly bodies, vacuoles, and bands, think severe infection or inflammation. When you see blast, nuclei, and fine chromatin, leukemia. That's how you differentiate these two. Toxic changes may appear in sepsis, pneumonia, severe inflammation, burns, and trauma. Toxic changes mean the marrow is responding fast and pushing neutrophils into battle. Well, that's the only time you would see that. Okay, let's move on to EOs. So eosinophils are going to be caused by asthma, parasites, and drug reactions and Hodgkin lymphomas. EOs, morphology, they're bi-lobed nucleus and large orange and red granules. So their main job is parasitic defense, allergic response, inflammation regulation, okay? EOs are granulocytes that play a major role in allergic reactions, asthma, parasitic infections, and inflammatory regulations. Think of eosinophils as specialized inflammatory fighters. Unlike neutrophils that mainly fight bacteria, eosinophils are more involved with parasites, hypersensitivity reactions, and allergic inflammation. The normal percentage for EOs is 1 to 4% of circulating white blood cells. Even though there are fewer in number, they are very important diagnostically. EOs equal, this is a memory trick, EOs equal allergies and worms. Again, their morphology is large orange red granules, bilobed nucleus, and uniform granules. They're the easiest ones to recognize, okay? And they stain brightly because they bind with eosin dye. Eosinophils look orange and sunburned. That's another memory trick. Orange and sunburn. Their bilobed nucleus. The nucleus usually has 2 lobes connected by a thin strand. This helps distinguish eosinophils from neutrophils. Neutrophils usually have 3 to 5 lobes or 2 to 5 lobes. Eosinophils usually have 2 lobes. Eosinophil Eosinophils granulars contain toxic proteins including major basic protein MBP, eosinophil peroxidase, and eosinophil cationic protein. These proteins help destroy parasites, but they cannot always damage tissues. But they can also damage tissues during allergic reactions, okay? One connection you can make for the MLS, eosinophils can contribute to tissue inflammation, airway damage to asthma, and allergic injury. There's a high yield for eosinophilia. Increased eosinophils are called eosinophilia. This is very important in MLS. I'm going to tell you why. Major causes of eosinophilia would be allergies, asthma, hay fever, parasites, hemolymph or worms, drug reaction, antibiotic reaction, skin disorders like eczema or malignancies, which can be Hodgkin's lymphoma. This is a trick. Eosinophil rise with allergies, asthma, and parasites. Parasite connection. Eosinophils are especially important against helminths, worms. They're granulates attached to the parasite surface and release toxin proteins, okay? Parasitic infections causing eosinophilia are usually tissue invasive parasites. Ew, nasty little buggers. Not all parasites cause eosinophilia, okay? Asthma and allergy connections, eosinophils contribute to bronchial inflammation, mucus production, and airway hypersensitivity. This is why eosinophils are commonly evaluated in asthma patients. Drug relations or drug reactions, eosinophilia may occur with antibiotic reactions, hypersensitivity syndromes, and medication allergies. Hodgkin's lymphoma association. Eosinophil can also occur in Hodgkin's lymphoma. This happens because Reed-Stern cells, remember Reed-Stern cells, if you see that, automatically think eosinophil. They release cytokines that attack or attract eosinophils. So eosinophilia plus Reed-Sternberg equals Hodgkin's clue. I don't want you to put nothing else down. This has nothing to do with basophilia. Eosinophil is associated with Reed-Sternberg Hodgkin's lymphoma. Low eosinophils are less clinically important, but may occur with stress, cortisol, steroids, and Cushing's disease or syndrome, excuse me. So what's the difference between basophils and eos? Eos have an orange-red granules. Their bilobe nucleus is visible, and they attack parasites and allergies. That's why they come about, and they are more common. Basophils have a dark blue granules. Nucleus is often hidden because of all the little pimples from the basophils or the granules, and they release histamines, and they are quite rare. So remember, orange and red is eos, dark and blue is basal. That's a memory trick. And for the MLS test strategy, if a question mentions asthma, parasites, allergies, or elevated IgE, think EO. If you see orange granules or bilobe nucleus, eosinophils should be your immediately go-to white blood cell. So here's a pearl again. Eos or granules are large, uniform, refractal, and easy to identify. This makes the eosinophil one of the easiest cells to recognize and differentiate. An eos response to the body is by fighting the parasites or overreacting to allergens. They help connect morphology. Remember, that will help you connect morphology, the function of why, the disease association, and differentiating between the interpretation. All right. All right, moving on, let's go to basophils. So your basophils function as histamine release and hypersensitivity reactions, and they contain histamines and heparins. Basophils strongly suggest myeloproliferative disorders such as CML. CML for basophils. Reed-Sternberg, Hodgkin's lymphoma for eosinophil. Basophils are the least common white blood cells in the peripheral blood smear, but are very important on the MLS exam because of their disease association. Think of basophils as an allergy alarm system. They're a major role in releasing chemicals involved in inflammation and hypersensitivity reactions. What do basophils contain? Just told you, histamines and heparin. They cause vasodilation, increased vascular permeability, and allergic symptoms. And heparin, also they can help with anticoagulants, okay? Sorry, my phone was buzzing. A memory trick for this, basophils burst with histamines and basophil morphology. You can recognize them, like I said before, by their dark blue purple granules, coarse granules, and granules that may cover the nucleus. The nucleus is usually bilobed, difficult to see because of the heavy granules, and a memory trick is basophils are dark and messy, like that picture here. Basophil granulars are large, coarse, deep purple, black, blue. These granulars are packaged with inflammatory mediators. And there's a high yield. Increased basophils are uncommon, so when you see basophilia, pay attention. Basophilia is strongly associated with chronic myeloid leukemia, CML. CML is for basophil. Reed-Sternberg Hodgkin lymphoma will be for eosinophil. It's very important. This is a very important pearl. Very high white blood cell count, left shift, and basophilia. Think CML. Why the left shift? What is the bone marrow doing? It's overcompensating. It's sending an SOS. Pay attention to the little clues. This is one of the highest yield leukemia association. Memory trick is basophilia belongs to CML. Other causes of basophilia may also be seen in allergies, chronic inflammation, hypothyroidism, and myeloproliferative disorders. But on the MLS exam, CML is the big association. So basophils versus eos. We just went over this. So basophils have a dark blue granules. Eos are orange and red. And basophils, their nucleus is covered by the granules. Nucleus is visible on the eos. Basophils release histamines. Eos are there to fight back parasites and allergies, and basophils are rare, while eos are more common. Basophils are dark blue, and eos are orange and red. Basophilia and mast cells. Basophils are similar to mast cells because both release histamines. The difference is basophils circulate in the blood, while mast cells live in the tissue. When you're identifying a basophil, remember look for very dark granules, obstructed nucleus, and coarse appearance. All right. And we're moving on. Let's talk about lymphocytes. So I like how, this nice little refresher here helped me realize some things. When I was calling these reactive lymphocytes, I was correct. People can get these confused where you see I have the eye and the hand pointed. These are reactive lymphocytes. So reactive lymphocytes like to cuddle the RBCs, and what are they doing? Look like they're trying to smother them, and literally they are cuddling all these RBCs. Their major job for a lymphocyte is for viral defense, immune memory, and antibody production. Lymphocytes are one of the major white blood cells involved in the body's adaptive immune response. Think of lymphocytes as the memory and intelligence team of the immune system. Unlike neutrophils, which respond quickly to bacteria, lymphocytes are more specialized and are heavily involved in viral infections and antibody production and long-term immunity. There are 3 types of lymphocytes that we are going to talk about, and these are the major ones. There's B cell for antibodies, T cell for attack, and NK, which are natural born killer cells. I like to call the lymphocytes like the special forces. This is the crew you call when you really got to bring the heat. And our neutrophils are more like our regular foot patrol police that's always there ready to take care of the perimeter at all time. But when they got to get on the phone and call the lymphocytes, oh, there is a problem. And there's no discussion once they come out, because they're there to come back and take over. So again, B cells produce antibodies, T cells regulate immune responses and kill infected cells, while NK cells, or natural born killer cells, destroy abnormal or infected cells. B cells make antibodies, T cells attack, and NK kills naturally. Normal lymphocytes morphology. So like a normal lymphocyte will be small to medium size, have a very large round nucleus, clumped chromatin. They have dark clump chromatin, a thin rim of blue cytoplasm. And classic, I have some more pictures up here. You're going to see they're going to have a classic look to them, and they really do. Lymphocytes are mostly nucleus, typically like the picture I have right behind the lymphocytes lettering here. The chromatin pattern is dense and clumped. This helps distinguish them from blasts. These are not blasts, okay? There's no one-eyed bandit in there that can't see the cyclops eye. Remember, mature cells equal clump chromatin. Immature cells have fine chromatin. The cytoplasm usually is light blue, scanty, forms a thin border around the nucleus. A reactive lymphocyte occurs when it's activated during a viral infection. So with this picture down here, if you see the 2 eyeballs, do you see this cell right above? That is a typical monocyte. You see the vacuoles, you see there's 2 lobes here. That one looks like it's kind of called folded in on its cells, but these are typical lymphocytes here, and they are reactive because of that scanty looking cytoplasm right there. The main cause of any type of viral infection could be the Epstein-Barr virus or the mononucleosis, CMV, and viral illnesses. Reactive lymphocyte features will appear large, irregular shape, deep blue cytoplasm, and the cytoplasm is hugging the RBCs. That's another memory trick for you. Reactive lymphs cuddle RBCs. Reactive lymphs are not blasts. Okay, do not get them confused. Reactive lymphocytes still have mature chromatin, are responding to infection. Blasts are immature. They have an immature chromatin and should not be out of the daycare schoolyard. They shouldn't be outside. They need to go back. And they have a very high nuclei. You'll see them a couple of times in there, or you just see one big one, which means there's some type of cell production going on, and they should not be outside. In lymphocytosis, you have increased lymphocytes may be seen again with viral infections, pertussis, and CLL. CLL connection with lymphocytes, chronic lymphocytic leukemia. Now, don't go overboard with this. The name of the dang leukemia is in the name. It's chronic lymphocytic leukemia, mature appearing lymphocytes and smudge cells. There'll be a bunch of those. Sometimes we get a set, we be like, oh my gosh, this is gonna be easy. Oh, they shouldn't have had all these damn lymphocytes here. The memory trick is CLL is crowded with little lymphs. Again, I forgot if that was even there. And I know when I see a bunch of little small lymphocytes everywhere, it's a problem. That is CLL. Too many crowded little lymphs. Crowded little lymphs is what it stands for, CLL. All of this connects. Acute lymphoblastic leukemia, that's the one for children. All my children are affected. This is lymphoblastic leukemia. Lymphoid blastic. Remember, we have to be able to differentiate between lymphoid leukemia and myeloid leukemia. Going to get into that in the following slide. Lymphoblasts, common in children, all affects all little kids. Lymphoids versus monocytes. Students often will confuse this. So lymphocytes, mostly nucleus, okay? While monocytes are more cytoplasm. Lymphocytes have a round nucleus, while the monocyte has a folded nucleus. Lymphocytes are small to medium size, while monocytes are the largest white blood cell. Lymphocytes have a dark chromatin, while the monocyte has a lacy chromatin. One question on the MLS will want you to identify a lymphocyte. When you do that, you have to look at the chromatin, the amount of cytoplasm, the nucleus size, and the oversize. It's the smallest, the medium. We just said it's small and medium. Do not identify using one feature. You've got to have 3. You can find 3 here. When we're looking at this reactive lymphocyte, look how it is hugging the RBC. It's a beautiful chromatin in here, and look at the cytoplasm. That's a no-brainer. This is truly a reactive lymph. If we go up above, we know that is a monocyte. Because of the nucleus is the gray here, even though this looks really big, but it is a monocyte nonetheless because it has the vacuoles. It looks like one of the nucleus is kind of folding on itself, and because of the appearance of this gray looking cytoplasm. Lymphocytes are heavily involved in viral infections, again, immune disorders, lymphoid leukemias, and lymphomas. Lymphocytes remember infections and keep and help protect the body long term. All right. Let's talk about monocytes. It's just another review. I went through all of these so you have a better idea of them. Okay. Monocyte morphology, the largest normal white blood cell. It has a folded nucleus and a gray-blue cytoplasm and vacuoles possible. So I put this picture up here because I wanted to talk about this. So look at this. This is a classic lymphocyte here. You can't even see the cytoplasm. And the nucleus is taking over the entire cell. It's classic. Okay, classic. And on this is a classic normal looking monocyte. You might want to call it in a phase, but it's not. It's not going through any other phases. This is a mature Monocyte, because let me tell you why. This monocyte is just not actively engulfing anything. There's not fighting anything. It may have just came off the showroom floor. It is not having to attack much. But look at the difference in the cytoplasm, in the chromatin on both. Look how dark the lymphocyte is. Look how scanty and purple the monocyte is. Look how gray the cytoplasm is on the monocyte. You can barely even see the cytoplasm on the lymphocyte, and it is that blue. This is how you would know the difference, and this is a small lymphocyte versus the largest white blood cell that would be in our system would be this. You cannot confuse this with a blast. There's no way. Do you see a nuclei? No, you don't. It's not dark blue. It's not giving all of that chromatin and all. There's no possible way this could be. You would probably be like, oh, this is a very large cell. It must be a promyelocyte. No, it ain't going to be that way because I got another slide for you and I'm going to show you why. Usually with a myeloblast, it's going to look like Giardia missing an eye. Do you see an eye? Do you see a nuclei anyway? No, it's not a one-eyed cyclops. When you're going through the promyelocyte, remember it's myelocyte pro. Pro looks like you put your palm down on a piece of paper, and that's how wide the chromatin is on the inside. Doesn't look like that at all. None at all. It's not scanty, and I still don't have a nuclei there, so I can't be a promyelocyte. When I go for my myelocyte, which looks like I'm putting my thumb down in some cake mix or something or in some ink and I set it down. This looks like a thumb, but it's missing something. It doesn't have the feature that I'm looking for. It's not big enough. This chromatin looks fine. It looks like it's not going in it's not under construction. This looks like a perfectly good cell. Then when I go to the meta is going to push in a little bit like, I'm bending in, I'm banding in, I'm banding in. Metal is always going to look like it wants to be a band, but it ain't quite there yet because my lobe is too big still. But there is no lobe because I don't have that banana look. Next after the metal would be the banana, would be my band because I'm almost graduating. Honey, all I got to do is get through the next couple of classes and then I'm going to be a full-blown neutrophil. Or what may have you, or whatever stage that particular cell is going to be. So it's metablast, promyelocyte, myelocyte, metamyelocyte, band, and then seg. That's how it goes. I got a little rhyme in here for you so you can see it. But back to the monocytes. So you're going to think that the monocytes are the garbage trucks and the vacuum cleaners of the immune system. Their primary role is phagocytosis, which means they engulf and digest foreign material and bacteria, dead cells, and debris. So they engulf foreign material, bacteria, dead cells, and debris. Where do monocytes come from? Well, monocytes come from the myeloid legion. I just went through that. So this is important because monocytes are grouped in granulocytes disorders, but they are a disorder of the myeloid leukemia on the MLS exam. What happens after the monocyte leaves the bloodstream? Well, they go into the tissue and they become macrophages. We know this because we see these in our body fluids. So macrophages continue phagocytosis and help activate the immune response. So it's like they move up a sweet level. I'm upgrading myself. Let me upgrade you, baby. That's what happens with a monocyte. So memory trick. Monocytes become macrophages, or mono leaves blood, macro cleans tissue. Monocytes and their morphology. Monocytes are usually the largest normal white blood cell, have abundant gray-blue cytoplasm, may contain vacuoles, have a folded kidney-shaped horseshoe nucleus, and for a memory trick, mono equals massive. Cytoplasm appearance, the cytoplasm also looks smoky, gray-blue. I don't know what ground glass is, but that always kills me when they say that. Ground glass appearance, and this helps distinguish monocytes from lymphocytes. Okay, look at the difference here. And then those vacuoles just mean it's actively involved in phagocytosis. Alexa, stop alarm. Vacuoles may suggest active infection, inflammation, cellular digestion activity, and monocytes have a high yield. Increased monocytes may be seen in chronic infections, tuberculosis, recovery from some type of infection, and some type of inflammatory disorder. There is a leukemia associated with monos. Monocytes often increase during recovery from acute infections. This can appear after neutrophils begin decreasing. So monocyte versus lymphocytes. Again, we're going to go over the key differences. Monocytes are larger, lymphocytes are smaller. Monocytes folded nucleus. The lymphocytes has a round nucleus. Monocyte has a gray blue cytoplasm. Lymphocytes has thin blue rim. Monocytes have more cytoplasm, while lymphocytes are mostly nucleus. When you're identifying a monocyte, look for size, folded nucleus, abundant cytoplasm, and gray-blue color. Again, do not identify cells using one feature. You gotta have 2 to 3. Abnormal monocyte proliferation may be seen in chronic myelomonocytic leukemia. You cannot miss this question, people. The name of the white blood cell is in it. Chronic myelomonocytic leukemia. Okay? AML with monocytic differentiation. Okay? CMML, AML. This is affected by monocytes. CMML, AML. I'm going to say it again. CMML is chronic myelomonocytic leukemia. AML with monocytic differentiation. Okay? Remember, monocytes are the body's cleanup crew before they become tissue macrophages. All right. So here we go. This is what I was talking about here. When we're talking about the maturation sequence is one of the most important pathways in hematology and heavily tested in the MLS exam. Myeloblast is first. You see that blast cell there? Do you see that cyclops looking dead at you? That big old eye. You see why I say it kind of looked like a Giardia cell from a stool sample? They're not always going to look like that. I know. But they're always going to be pretty in blue. And they're going to have numerous of those. So be on the lookout. Then we're going to go to that myelocyte. I do not want you to just memorize this order. I want you to understand what's changing as the cell matures. The biggest changing during these maturations are nucleus-shaped chromatin pattern and granules, ability to function. All right. As the cell matures, the nucleus becomes smaller. And you can see that just looking at it. Okay. And more condensed, because I'm pulling it all together, people. I'm snatching my waistline. Let's look at it like that. The chromatin becomes clumps, putting it where it needs to go. And then the cell becomes more functional. Now I'm packed. I got it where it needs to go. I'm ready. Break me out the box because break me out the plastic because I'm acting brand new. So a myeloblast, this is the earliest recognizable granulocyte precursor. Bam. Cyclops. Booyah. You're going to see that dang eyeball looking dead at you. Promyelocyte. Let's go on. We're still on the myelocyte. Myeloblast. Very large nucleus, fine chromatin, nuclei present, very little cytoplasm, no specific granules. None whatsoever. It actually looks like it could be like, what are we doing here? Why is this cell here? And it don't look right. Now I see more of those. I'm going to get suspicious because I should not see a cell without a cytoplasm. Okay. This cell is immature and normally stays in the bone marrow. Get back in your yard and go back in the house. You ain't supposed to be outside. Blasts look young and open. What I say? Get back in the house. Promyelocyte. Promyelocyte is slightly more mature, but not enough. The primary granules appear a little bit. The granules are light and dark. The nucleus is still immature with visible nuclei. You see that dang eyeball right there. Even if it look like it ain't connected, but you see how the cytoplasm trying to disconnect. It still don't look like it's supposed to be outside. So let's go to the third stage where I say it looks like our thumbprint, right? That's the myelocyte. The myelocyte this is an important stage because specific granules first appear here. Yes, this is how some of us get kind of tripped up when we see a lot of granules, like not even a lot. They'd be like little pink or purple ones, depending on how they stain. And we're like, dang, is this a monocyte? Is this a promyelocyte? Is this a myelocyte? Well, we know it is a myelocyte. At this point, the cell is committing to becoming either a neutrophil, eosinophil, or a basophil. This is where it's going to tell us what stage it's going to. I'm picking my specialty at this point. The nucleus becomes more condensed and the nuclei disappear. Because guess what? Do you see an eyeball? Cyclops has retired. Okay? The myelocyte's first specific identity. Remember, the myelocyte is important. It's important right here. If y'all don't remember nothing else, this is the third stage of it. Important. Trade is important. Next is the metamyelocyte. My meta is pushing in. I'm pushing in because look at that. See how I'm pushed to the side, to the edge here? I'm about to become something, y'all. Look at this. But I can't really call you a band. But you're giving band appearance because my band is right up underneath you because I am more shaped like a banana down there. This stage is more mature. It has a kidney-shaped nucleus. The chromatin becomes darker and more clumped, which it does, but it ain't a band. It's a metamyelocyte. Remember, meta equals band nucleus because I'm pushing in. I'm doing the Charmin right in there. The band neutrophils is the next one. Band neutrophils are immature neutrophils released from the marrow. It has a horseshoe-shaped nucleus, which it does exactly have. There are no true segmentations yet, and bands increase during infection and inflammation. So when we see this coming out, there's an increase in infection and inflammation. We don't want to see these anything above this band. I don't want to see that. Why are you outside? This one here just barely able to come outside while the street lights is still, not on yet. The other ones need chaperones. So let's break it down. When you have increased bands, going to equal left shift, correct? This means marrow is responding to stress or infection. Segmented neutrophils. This is, I'm fully grown. I'm on my own. You can't tell me nothing. Give me the keys. I got to go. That's the neutrophil. We got 2 to 5 lobes. We got a clump chromatin, and we are fully functional. The major job for a neutrophil is bacterial defense. Segments are the final soldiers. Granulocytes are mature nucleus condensed, chromatin clump, nuclei disappear, cell becomes more specialized. Immature cells, we got open chromatin, nuclei, large nucleus all over the place. Mature cells, clump, chromatin, segmented nucleus. This is important for your exam. If immature cells appear in the peripheral blood, ask yourself, is this an infection? Is this caused by left shift? Is this leukemia? Or is this some type of bone marrow stress? So remember this pattern I have here for you. The exam often tests whether immature cells are reactive or malignant. Remember this easy flow? Blast, pro, my, meta, band, seg. Blast, pro, my, meta, band, seg. Blast, pro, my, meta, band, seg. You got it? All right. Let's keep it moving. All right. Now we have these blasts here. All right. Blasts are not normal in blood, and we know that because we're going to think acute leukemia, bone marrow stress. So with these pictures here, A rods will only appear in blasts. Era rods, I'm going to call them A rods, you know how I am. The needle-like inclusions are found in myeloblasts. They are not found in anything else. So if you thinking you seeing a rod in a neutrophil, you're not. It ain't doula bodies. That's a doula body. That's not an A-rod. Okay, it's not an A-rod. You will not see this in a lymphocyte. No, 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 no. They're only in a myeloblast. And this is associated with AML. AML is associated with A rods. Okay? AML. And it's in the myeloblast stage at the beginning, in the blast, at the beginning stage, very first stage. That's my cyclops right there. If you see number 1 over here, you have roughly 3 cells that are normal. You got 2 cells here and 1 little lymphocyte all the way to the far right corner. But do you see that big old myeloblast? You can't miss that cyclops. You see that big eyeball right there. Then they got that promyelocyte right there. You see that. You would want to call that a blast, but it's not, because it does not have that big old nuclei there. It don't have that pretty blueness around the cytoplasm either. And look how the chromatin looks. It's totally different. So don't get them confused. You got number 1 here, which is the myeloblast, and then you have the promyelocyte over here, which would be the second stage. Then you have this third stage, and we got a couple of them in here. The fourth stage, which would be the metamyeloblast. You see that little bend? It ain't quite a banana. It looked like a whole little bean kidney here. And, we got a couple of those there. And then you got that little bow tie one that looks like it was almost ready to make a load, but, we came out too fast. And we literally identified all of these white blood cells in this one cell here, because we just reviewed everything. Don't you feel accomplished today? I know I do. So remember, ARODs are acute myeloid leukemia. Blasts, woo-woo. Let's try to recognize them. Blast recognition is one of the most important skills in hematology, because blasts are strongly associated with acute leukemia. When you look at blast cells, think this cell looks immature. Blasts are very young cells that normally belong inside the bone marrow, not circulating in large numbers in the peripheral blood. Large nucleus. Blasts have very large nucleus because the cell is immature and focused on growth and division rather than function. The nucleus usually takes up most of the cell. Fine chromatin. All those have fine chromatin. The chromatin in the blast looks soft, smooth, and open. Mature cells have clump chromatin. Immature cells have fine chromatin. This is one of the biggest clues for identifying blasts. Nuclei. Those big eyeballs, that cyclops there. All you got to do is find one of those, and you're going to see others once you find that. Nuclei look like lighter circular areas inside the nucleus and indicate active cell production. The more prominent the nuclei, the more immature the cell tends to appear. Can't make this stuff up. There's a high nucleus to cytoplasm ratio in there. This means high nucleus to cytoplasm ratio. The nucleus is very large while cytoplasm is minimal. This is another classic immature cell feature. Blasts look young and open-faced. Young cells, open chromatin, large nucleus, visible nucleus. Blasts in peripheral blood should immediately raise questions: acute leukemia, severe marrow stress, and marrow infiltration. Blasts are immature cells where they should not be. Now, how do we tell the difference between acute and chronic? Well, when we have acute, it's usually aggressive. It's rapid. It's terrible when we see this, because it's like, oh my God, this person must feel like crud, because we can see their blood and we can look and tell like, oh, this is terrible. And chronic leukemias are more mature and slower. This person's been for a while. They're probably having a moment. We're going to make them feel better, and they'll go on about their day. But remember, acute is fast. Acute progresses rapidly, and patients often become ill very quickly, just out of the blue, just one day, I don't feel good. Bam. Symptoms include fatigue, bleeding, infections, fever, and blast, of course. Acute leukemias are dominated by blasts. Acute immature cells everywhere. Get y'all bad behinds in the house. You ain't supposed to be there. It's overran by children. Get in the house. Get in the house. The marrow becomes overcrowded with non-functional immature cells. Very sick patients with acute leukemia are usually systematic and may present as a medical emergency. We've seen it a couple of times in our field. Without treatment, acute leukemia progresses rapidly and can become life-threatening. Chronic leukemia is slow. Chronic leukemia develops more gradually. Mature cells, you're going to see older cells out there. These cells are more mature, may still function somewhat. I got a little something in me. This is why patients can sometimes appear stable early on, maybe incidental. Some chronic leukemias are discovered accidentally on routine CBCs. We've seen that. So symptoms may develop slowly over time. Remember, one trick is acute is baby, chronic is grown-up cells. So once you see blasts, remember you may see severe symptoms, rapid progression. If you see that on a test question, immediately go to acute leukemia, especially if it's talking about something that has to do with RBCs and white blood cells. Mature cells, very high white blood cell count, slow progression. You're going to think chronic. How do we differentiate between myeloid and lymphoid lesion? All right, let me tell you. So when you have a case of chronic versus leukemia classifications, depending heavily on lineage, myeloid lineage cells produce the most. M for most. Granulocytes, monocytes, RBCs, platelets. When leukemia affects the myeloid line, you're going to see granulocytes, abnormal Ts, ARODs, MPO positivity, AROD possibilities. ARODs are only associated with myeloid blasts. You just seen that lineage. I put there the myeloid progression, myeloid blast. That's the only cell that is associated with AROS is in the myeloid feature, and that is AML. Okay? And we're only going to see that in the myeloblast. If you see AROS, you're going to immediately think AML, myeloblast. Lymphoid is in our VIPs, our secret servicemen. Come on, they under attack. B cell, T cell, NK cells. That's the difference. Most for myeloids. That's everything that we get on a regular. And then for our lymphocytes, we go into our specialties, our departmental people. Think of my VIP. Can't nobody get in there. This is by invitation only. My secret servicemen, my black truckers, they coming through. My sniper. Those are the ones that are affected by the lymphoid leukemias. Those are the ones we have to send out for flow cytometry. So lymphoid leukemias do not produce AROS. If you see that, don't even associate that with the lymphoid process. Myeloid is most. We're going to see that. Lymphoid is more specific. I got to figure out which one of my VIPs, my secret servicemen, my specialty group is going to have to be taken care of or where it's having a problem. Myeloid makes most. ARODs, myeloid clue. Important connection, lineage, maturity, morphology, and association markers. This is why understanding the myeloid versus lymphoid is foundational in leukemia interpretation. Like once we get to 4, you'll be ready because I'm already going over a lot of this now. Remember, the exam wants you to classify before you diagnose. Almost done, guys. So automated versus manual differentials. Manual differentials indicate when immature cells present, blast flags, abnormal scatter plot, instrument flag. So when you're getting a flag, don't ignore it. Go on and make that diff. It's not going to take you but a couple of seconds. Let that thing dry, stain it, and go on over there and look at that patient under the microscope because we're there to help. Remember, we are detective. Let's detect so this patient don't have to keep coming back and forth in here. So when we're reviewing cells, we want to be looking at the size, the nucleus shape, the chromatin pattern, the cytoplasm color, and granules. Are they present or are they not? If your slide is crappy, make another one. It only takes a second. I made this little chart here. It could help you when you are looking for buzzwords and association, because that's what the MLS exam is going to be quizzing us on. So sometimes one clue in the question will point directly to the diagnosis. I want you to train your brain to immediately connect these findings with disease process. ARODS, AML, only in the myeloblast. I'm drilling it in your head. ARODS are, and I'm saying it wrong, I know. ARODS are red needle-like inclusions found inside myeloblasts, only in myeloblasts. It's part of the myeloid lineage. Think acute myeloid leukemia immediately. This is one of the highest yield hematology associations on the MLS exam. Okay. Important reminder, ARODs are not found in the lymphoid. Remember, Secret Service men, black truckers, our specialty group. That's our Secret Service, is the lymphoid. And that would be our B cells, T cells, and our natural K cells, our natural born killers. Secret Service. AROD points toward AML. Smudge cells, classic CLL. See that in a lot of older people, and we see that in babies because their lymphocytes are fragile, and that can rupture during slide preparation. And that's why we see them, and that's why sometimes we put albumin in there to keep the cells together. Isn't that crazy? I learn something new all the time. These are classically associated with chronic lymphocytic leukemias. These patients often have many mature-looking lymphocytes that are very fragile. So CLL gets smudgy. That's a good way for you to remember this. CLL gets smudgy. Important. CLL is usually seen in older adults. Basophilia is associated with CML. An increased number of basophils is strongly suggestive of chronic myeloid leukemia, right? Not CLL. Very high white blood cell count, left shift, basophilia. Think CML until proven otherwise. Important associations, CML is linked to Philadelphia chromosome T922. Look that up and tell me what that is. I didn't put it up here for a reason. Philadelphia chromosome T922. I got to start sending y'all some practice stuff. I have gotten away from it. My apologies. Remember, basophils become big in CML. Reed-Sternberg cells, Hodgkin lymphoma, eosinophil. Right off the rip, Hodgkin's lymphoma. Reed-Sternberg cells. These cells are often described as owl-eyed appearance because of their large bilobe nuclei. If the exam mentions Reed-Sternberg cells, the answer is Hodgkin's lymphoma. I don't want to see. Don't say me you forgot. Don't say that. And childhood leukemia is all my little children. Mostly common in children. It is acute lymphoblastic leukemia, all. Lymphoid blasts, common in young children, often responds well to treatment. The memory trick is all affects all the little kids. The MLS exam rewards recognition. Many leukemia questions can be answered from one clue word alone. Okay, make flashcards. Go over this little list here because I'm going to start sending you this, and I want you to think about what its association means. Okay, let's get this done. This section is meant to train fast thinking. This is called rapid recall. Because the MLS exam moves quickly, I want you to begin recognizing association immediately without overthinking. Which cell contains histamines? Basophils are involved in inflammation and allergic response. They release histamines and heparin. If you see basophilia, especially with very large white blood cell count, start thinking about CML. Which cell becomes a macrophage? Monocytes. Once monocytes leave the bloodstream and enter the tissue, they mature into macrophages and become part of the body's clean up system. Through phagocytosis. What does a left shift indicate? Left shift indicates an increase in immature neutrophils, particularly bands circulating in the blood. This usually indicates infection, inflammation, or narrow stress. Think of it as the marrow pushing cells out early to fight a problem. What disease is associated with ARODS? Acute myeloid leukemia, AML. Acute myeloid leukemia, or AROS, are needle-like inclusions found inside the myeloblast and are a major high-yield clue to AML. Questions on the MLS. All right. I wanted to do this one as well. This slide is probably one of the most important slides of the week because, this is how you should approach morphology questions on MLS. When you see an abnormal white blood cell or a smear question, stop and ask yourself 4 things. Is this reactive or malignant? Is the body reacting to infection or stress, or does this look like cancerous? Reactive changes usually still look organized and purposeful. Malignant cells often look immature, abnormal, and uncontrolled. An example would be reactive lymphocytes, a viral infection, while blasts are for leukemia. Mature or immature. Look at the nucleus and the chromatin. Mature cells equal clumped chromatin and segmented nuclei. Immature cells have fine chromatin, nuclei, high N-to-C ratio. The more immature the cell looks, the more concerned you should become. And let's talk about lineage here. Myeloid or lymphoid. Remember, myeloid means most. What helps narrow down leukemia questions quickly? Is it a blast? There we go. Easy peasy. Do it have blasts? That's it. What is bone marrow response? Ask yourselves, is the marrow responding appropriately? Are retics elevated? And what else happens if a retic? We learned that last week. Elevated bilirubin, especially in children. Elevated bilirubin because the RBCs are being destroyed at a very high rate because the baby is finally breathing on its own. Anytime you see high levels of reticulocytes in an adult or a baby and the bilirubin is up, we've got a problem. Houston, we got a problem. Remember, if this has something to do with vitamin B12 or folate, we're looking at a DNA problem, especially when it comes to the lobes in our neutrophils, because we know it's going to be some neurological problems because those are issues, our telltale sign that something is going on internally. Well, we already know something's going on internally, but we know it's something going on within our white blood cells, and that means there's something going on within our blood cells. Our blast appearing, is it left shift? The marrow tells you whether the body is compensating stress or failing. What I just say? You can't make this up. Let me tell you something. Morphology questions are detective questions. And remember, we are the detectives and we are here to do the work. Okay. So let's wrap this up. This week was all about building a visual recognition and interpretation skills. Morphology matters, and the MLS exam expects you to recognize cells, quickly correlate them with disease states and shapes. Nucleus, granulocytes, chromatins, and cytoplasms all matter. Maturation sequence is critical. You must know the granulocyte maturation. Myeloblast, promyelocyte, myelocyte, metamyelocyte, band, and segmented neutrophil. Remember, myeloblast, promyelocyte, myeloblast, metablast, bond, neutrophil. Toxic changes versus blasts. Learn the difference. Toxic changes usually indicate infection and an active marrow response. Blasts indicate immature malignant cells and possible leukemias. Do not confuse reactive changes with malignancies. Practice differentials daily. The only way you improve your morphology recognition is repetition and exposure. Review all cell images daily. Perform manual differential practices. Compare normal versus abnormal cells. And use the media lab. Spend the money, people. It is quite helpful. The more cells you see, the easier hematology becomes. Oh my gosh. Thank you so much. You don't know how many times I've been trying to hate this audio today. It better save, because if not, I'm throwing the whole thing away. Remember, the theme for next week will be too many baby cells equal big problems. Next week, or we're going to be talking about stop being afraid of leukemias. We're going to learn about patterns instead of memorization and everything. And we're going to recognize acute and chronic. I touched on it this week. And we're going to recognize myeloid versus lymphoid, and understand blast and bone marrow failure. Thank you so much. Thank you for your patience. I know I'm a busy person, but if you need anything, please do not hesitate to text me or call me, and I would be more than happy to help you. Have a wonderful rest of the week, and do not stop studying. Keep it up, people. We've got a little bit more time. We got this. We got this. We got this. We got this. Have a good one.